Hello, everyone. My name is Emilia Tylenda, and I'm a senior research assistant for the Prevention and Early Detection team at the Applied Research Collaboration East of England. I'm based at the University of Hertfordshire, and today I would like to tell you about our work on bowel cancer screening in the East of England and our evaluation of a tailored educational intervention. So this project was led by Professor Daksha Trivedi. And today she couldn't join us. However, there is my manager, Claire Thompson. So I will be presenting, and then for the Q&A session, Claire, like if there are any questions that perhaps she would be better suited to answer, she will join us. So I will start with some background. So bowel cancer is the fourth most common cancer in the UK and the second leading cause of cancer-related deaths. Screening enables early detection, which significantly improves survival rates. The NHS bowel cancer screening program provides kits every 2 years to people aged between 50 and 74, and the national uptake varies between 65 and 70%. However, participation tends to be lower among certain ethnic and religious minorities and in deprived areas, which contributes to avoidable health inequalities. South Asian communities consistently show reduced uptake compared to the general population. Primary care data indicates that within this group, Muslims have the lowest participation rates, and some studies report that it's as low as 30%. Generic awareness campaigns and postal screening invitations appear insufficient. Research highlights culturally tailored, community-based approaches as more successful due to fostering trust, relevance, and accessibility. So now let me tell you a bit about the intervention itself. So the British Islamic Medical Association has worked with community stakeholders, healthcare professionals, and community members to co-develop a tailored educational intervention to improve the uptake of bowel cancer screening. The intervention is built on a culturally adapted version of a Cancer Research UK presentation, and those adaptations make the content more relevant and relatable. The intervention is faith-based, so it's delivered in mosques, what helps to overcome barriers of access and trust. On-the-spot translation removes language issues, and sessions led by primary care clinicians of the same heritage as the audience make the experience more personal and reassuring. So this approach, it goes beyond sharing information. It also builds trust and strengthens community connection. So our project was a collaboration between the University of Hertfordshire, BIMA, Applied Research Collaboration East of England, and NHS England. Our goal was to evaluate the acceptability, accessibility, and the impact of the intervention. We selected mosques in Luton and Peterborough because these towns have low bowel cancer screening uptake, high prevention levels, and large South Asian Muslim populations. We recruited 135 participants aged 56 and above. The reason they were aged 56 and above is because at the time of the study, that was the minimum age of eligibility for the bowel cancer screening program. Our study used a non-randomized mixed methods design, comparing intervention and control groups, with follow-up data from the NHS Bowel Cancer Screening Hub over 2 years. We also sought feedback from the clinicians delivering sessions. Our preliminary findings were encouraging. So participants in the intervention group demonstrated an immediate improvement in understanding and more positive attitudes towards screening. NHS data showed increased screening participation among attendees, suggesting sustained behavioral change. Participants with no prior screening history were 20% more likely to undergo screening in the 2 years following the session compared to the control group. Our data showed that women were generally less likely than men to screen, but the intervention still improved their uptake compared to the control group. Our qualitative data suggests wider benefits of the intervention. So participants reported discussing cancer screening and symptoms with close family and friends, showing ripple effects beyond the session. Clinicians who took part in the study spoke about stronger relationships with local communities. They felt the sessions were much needed to raise awareness and break barriers to screening. Our qualitative data gave us a bit more insight as to why the intervention worked well. So it highlighted participants' appreciation for culturally tailored content. Delivering sessions in mosques created a safe, familiar environment, which was more comfortable for sensitive discussions than clinical settings. And gender concordant groups boosted women's attendance and engagement. Clinicians sharing participants' heritage were able to build rapport quickly and tailor the delivery to the needs of the audience. And participants also said that verbal interactive delivery with visual aids enabled better participation, while real-time translation into preferred languages helped ensure clarity and better understanding. So during our data collection, participants highlighted a range of barriers that make it harder for people in their communities to take part in screening. The biggest challenge was simply access and engagement with healthcare services, which resulted in a low awareness of screening and its benefits. A common misconception was that screening is only needed if you already have symptoms. Language barriers, past negative experiences in healthcare settings, and low confidence also played a role in shaping how comfortable people felt when seeking care, but also engaging with screening. Practical issues were common too, for example, misunderstanding test instructions or not feeling able to ask for help. Fear, fatalistic beliefs about cancer, and the effects of poor mental health or trauma often created a gap between knowing screening is important and actually taking part. Cultural factors also influence engagement, particularly for women, as some topics were felt inappropriate to be discussed in mixed groups. So these findings have important implications for what equity-driven practice looks like in action. Our interviewees often mentioned language barriers and low confidence in their English as some of the reasons they struggled to engage with healthcare, including taking part in screening. So taking patients' preferred first languages into account is essential, because when people receive information in language they understand, they're far more likely to engage and make informed choices. Our interviewees also highlighted the respect and trust they have in their GPs. So letters from GP surgeries that inform patients about screening and encourage them to take part also can make a big difference. Similarly, making direct verbal recommendations during unrelated health appointments helps seize everyday opportunities to raise awareness. And finally, cultural and gender dynamics need to be taken into consideration. So, for example, mixed gender health sessions can sometimes discourage women from attending. So offering women-only spaces or alternative formats can make participation more comfortable and equitable for all. Our study highlights how primary care can help advance health equity using culturally adapted, community-rooted approaches. Faith-based interventions seem like a practical, scalable way to improve screening uptake in undeserved groups such as South Asian Muslims. Now I would like to share a few insights from the project. So first of all, tailoring interventions to specific communities helps health messages connect better. Training healthcare staff in cultural competence, such as fostering curiosity, reflection, and avoiding assumptions, makes a difference. Partnering with faith institutions can offer a cost-effective path forward, but it takes time to nurture those relationships. And making health communications linguistically and culturally accessible with visuals and perhaps interactive aids beyond just translations can remove key barriers. Expanding this model through local networks of professionals, faith leaders, and community groups could help reduce disparities, build trust, and support healthier, more inclusive communities across the UK. In terms of our plans for the future, we're now working on adapting the intervention framework to the needs of South Asian Hindu communities. And we're then hoping to pursue a larger scale study to explore the impact of the intervention. And we're also working on strengthening our partnerships with primary care professionals, community groups, and other stakeholders. Okay. Thank you so much.